welcome to our incredible leadership that has gathered from many of their clinical environments. We see Dr. Stock here, our co-chair for the Bay Area, is calling in from UCSF, where she is doing procedures today. So she will be coming in and out of the meeting and will be a bit less active than usual because she's doing patient care at the hospital today. Thank you for stopping to be with us. And thank you to the California Department of Public Health for joining. We have the Director of Chronic Disease and one of the major leaders at the California Department of Public Health with us. Dr. Jessica Nunez de Ibarra is still connecting to audio. I want to thank particularly our infectious disease people for coming together and thinking together scientifically as a community about this critical moment in human history, really. The decisions that we make, the decisions that Dr. Reingold, Dr. Kaplan, Dr. Criqui, and our many wonderful physician and clinical leaders, pharmacists, and population health managers are making are truly more life and death than ever. So thank you to our sponsors, including the biotech community that supports this work, as well as the Santa Clara Health Trust, Blue Shield of California, both of which helped us start the Santa Clara, Silicon Valley, Bay Area chapter. I am going to quickly turn this meeting over to our co-chair, Dr. Nurali Vora, neurologist from Stanford. And let's just move through the slides here. I don't see the slides I was going to show, but okay, here we go. Our co-founder, Warren Barnes, came up with our motto, which is we compete against disease and not each other. Next slide, please. So the model that we've been working from is really to synthesize the best practices to drive down the #1 killer pre-COVID, cardiovascular disease, and also managing diabetes, because that's such an important comorbidity. And it turns out that cardiovascular disease, next slide please, is also incredibly important to manage, to have better COVID outcomes. So just a note that in the Bay Area, we have a variation in performance, but we do have some high performers. And we may have some data collection problems here, but I want to just remind everyone to stick to your guns on driving down heart attacks and strokes and diabetic complications, so that you don't take the eye off the ball of the other things that are impacting our hospitals so terribly. So these conditions need to be co-managed. We have good indications, next slide, that both statins and blood pressure medications are important for better COVID outcomes. Next slide, please. So with that, I will just say that we have a great deal of our leadership from across the state with us today. And next slide, please. So this is the rundown of the program today. We will first hear from the chair of the California State COVID-19 Vaccine Workgroup, longtime colleague, Art Reingold, who is the guru of infectious disease epidemiology and biostatistics at UC Berkeley School of Public Health. And it's nice to see you again, Art. With that, I'm going to turn over the discussion to our co-chair, Nirali Vora, who will facilitate the agenda for the
Thank you,
beginning of the day.
Hattie. Thank you, Hattie, and thank you everyone for joining us. We have a powerhouse today, and I think it's going to be really exciting. All of you are facing, some interaction with COVID-19, and I think that, as Hattie mentioned, we are laser focused on preventing death from cardiovascular disease, but these are the same patients who are at risk for COVID. And so, with the vaccine on the horizon, we need to think about the science and the implementation of getting patients their care and preventing death in this aspect. And so it's my great honor to introduce Dr. Reingold, who has a distinguished career in public health focused on vaccine preventable diseases, including almost a decade at the CDC, and chief of epidemiology at UC Berkeley School of Public Health, and current chair, as you heard, of the California COVID-19 Task Force. And I'm not sure if he could have predicted our current crisis when he wrote his paper on infectious diseases of the 21st century, but I'm really excited to hear his expertise now on the vaccine from an epidemiology perspective, and hopefully stimulate some great debate within our group here and our other speakers. So with that, Dr. Reingold, why don't you take it away?
Thanks, Dr. Vora. I appreciate that. Can you hear me okay?
Yes.
So
Yes.
let me just say that I took my statin this morning. I took my lisinopril, but I still can't find a dose of vaccine. So
Exactly.
if anybody out there has an extra dose, I'll be happy to rush over.
Yeah.
So anyway, thank you. There are two challenges for me today. One is it's a relatively brief period of time and a huge topic. And had I made the slides this morning, they would still be out of date by this afternoon. And I made them a couple of days ago. So they are out of date because the situation is changing every day. But I'm hoping to go through some things and then talk about a lot of others in the Q&A. And I know that Dr. Criqui and others will present some interesting material after me. So I'm just going to give a very quick perspective on COVID-19, the pandemic and the vaccines. And then we're going to get into a discussion about perhaps with the other speakers, how we can use them better. So if I could have the next slide. So this is just to point out, as you all know, that this coronavirus is now basically the 7th coronavirus that's now known to produce human illness. 4 of them produce upper respiratory infections, but 2 of them produce very severe illnesses, SARS and MERS. If the next slide, I just want to remind you of the SARS outbreak that occurred almost 20 years ago, that started in South China, spread to 25 countries or so, affected about 8,500 people, including many healthcare workers, and killed almost 1,000 people. And I think that it's worth pointing out this epidemic, if you will, because I think some of us made incorrect assumptions about the coronavirus epidemic this year based on what happened with SARS, because SARS was a novel coronavirus. It emerged in China. It spread to other countries. And fundamentally, prevention and control strategies without a vaccine were able to put it back in the bottle and to stop the outbreak. And no more cases have been noted since August of 2003. So people like me, to a certain extent, a year ago, said, well, we can hopefully do the same thing with COVID-19. And that turned out to be obviously quite incorrect. The next slide. And just, back in January of last year, I heard about this. I suggested we have a talk on it at Berkeley. They said, oh, sure, why don't you do it in March or April? I said, I actually think this is going to be a little more interesting to do sooner. So I gave my first talk on the subject on February 6th. And at that time, there were 12 confirmed cases in the United States, 6 in California, and 6 outside of California. And of course, as you know, many people, including political leaders in Washington, took this as a sign that this could be easily controlled, and it wasn't a big deal. The next slide. So this is from the New York Times yesterday, just showing you that we did not manage to put this one back in the bottle. So these are confirmed coronavirus infections in the United States. over 25 million confirmed infections, about 420,000 deaths. And you all understand quite well that this is a fraction of the infections that have occurred, and almost certainly an underestimate of the deaths, as I'll come back to in a minute. And the next slide just shows that this is a national problem. We in California certainly are having our share of problems, most recently in the Los Angeles area. But in fact, the highest rates of COVID at the moment are in relatively rural counties, particularly in the Midwest and in the South. A much bigger population here in California. The next slide. And the result of this is, of course, an enormous burden on our healthcare system and on our hospitals, what we've been trying to avoid through, quote, flattening the curve. And we now have parts of the country on the Texas-Mexico border and elsewhere where there basically are no ICU beds, and we have a real crisis with healthcare delivery. And as Hattie mentioned, this obviously has impacts on other types of healthcare delivery, which we'll get back to. Hattie asked me to put in a couple of additional slides. We know that the number of reported infections is a very poor indicator of what's happening. So these are death rates per 100,000 from COVID in various states in the United States. So overall in the last year, in the United States, the death rate's about 125 per 100,000. Again, this is an underestimate for various reasons. But you can see within the states, California ranks about in the middle here, with New York and some of the New England states having been heavily affected early on last spring. And some states like Hawaii and Vermont having quite low rates of mortality. And the mortality rates are clearly a little more reflective of what's going on with regard to this pandemic. Hawaii has the advantage of being a set of islands, and islands are generally easier to defend against than other types of settings. But Vermont, for example, is not an island and has actually done quite well. The next slide. And of course, globally, we're now at about 100 million confirmed infections. Again, a gross underestimate, probably by a factor of at least 2 or 3 of the number of infections that have occurred, and a couple of million deaths. And the next slide just shows that in addition to the United States, as many of you know, there are parts of Europe that are now, again, heavily affected. Brazil and a number of other Latin American countries are quite severely affected. There really are very poor data from a number of other countries, as we'll come back to. The next slide. So again, the death rates that Hattie asked me to put, so you can see these are death rates per 100,000 from COVID, and you can see that the highest death rates reported nationally are actually in European countries. The US trails by a little bit, but not by much. But Mexico, Brazil are certainly having enormous epidemics. And then you have these interesting small numbers. I have to say that I just learned yesterday that 2 of my colleagues in Zimbabwe, one a Stanford physician who was doing research there, and one a Zimbabwean physician, both of whom I've worked with for many years, both died of COVID in the last few days. And so I think one could easily envision that these are underestimates because of poor diagnosis and reporting of COVID deaths, but we really don't know what's happening in large parts of the world, particularly in sub-Saharan Africa. On the other hand, Japan, this is probably a fairly reliable number, and Japan has certainly done so far a pretty good job of preventing COVID and COVID deaths. The next slide. And so this just, again, taken from the New York Times, and basically makes the point that even the deaths we count are undoubtedly an underestimate of the number of COVID deaths, or deaths that might be occurring because we're so busy dealing with COVID that we're not dealing correctly or appropriately or in a timely manner with heart attacks and strokes. So these are just graphs of excess mortality in different countries, irrespective of cause. And so by these types of measures, there really is an even bigger death toll as a result of this pandemic, at least in many countries. The next slide. So before we get to the vaccine, what other approaches do we have? Well, they should be familiar to you. Some of them are things we're promoting, such as hand washing and masks and face coverings and the like. I would argue that some of them, like environmental decontamination, are more security theater and aren't really making much of a difference. But certainly isolation and quarantine and some of these other measures, particularly the social distancing, have been used and have had enormous impact on people's lives. We'd like to think they've also had an impact on the spread of the virus to a certain extent. The next slide. You know, again, I think there's evidence that in places that take masking seriously, that really think about what the types of gatherings of people are critical and which are not, which to restrict, et cetera. There's certainly evidence, and epidemiologically you would expect these measures to reduce transmission of the virus, but they're very hard to maintain, and people really lose patience with them. So flattening the curve is often a temporary phenomenon. The next slide. And of course, all of these various things we're doing to people in terms of travel restrictions and closing restaurants and whatever are having enormous impacts on travel and trade, on people's ability to make a living, on small business owners. They've also had other types of impacts on society, and some people have questioned whether it's worth it, whether the cost we're paying is worth it in terms of preventing transmission of this virus. The next slide. This is another example taken from yesterday's newspaper, a suggestion that deaths from alcohol and drug use and suicide may be increasing because of isolation, social isolation and the like. So these are really important things to worry about. The next slide. And again, as particularly you healthcare providers know, this has led to enormous reductions in regular prevention activities such as childhood immunizations, reductions and delays in surgery, and probably a poor care of medical emergencies such as stroke and heart attack. The next slide. As I said, some of you may know, particularly since some of the people who pushed this notion are at one of our California institutions, some people have put out this Great Barrington Declaration that basically says that the cost of all these prevention control measures on society is too great. Most people who get the virus won't get that sick and will recover. We should circle the wagons around the frail elderly in nursing homes and let the virus go, if you will, so we can achieve immunity. And you're welcome to look up this Great Barrington Declaration. I don't subscribe to this view, but people with very august titles in various institutions have signed this declaration. The next slide. Well, in our country, there are a number of factors that put you at increased risk of infection with the virus, particularly relating to the kind of job you have and whether you have to be in contact with other people or not, delivering food or working in a grocery store, et cetera. Household crowding, living in a multi-generational household, certainly in California, being Latinx is associated with an enormously increased risk of infection, as is being Black or Native American. When it comes to severity of COVID-19 illnesses, age is a critically important factor, and a substantial proportion of all the deaths are in fact in people over the age of 75. But younger people can succumb or be seriously ill, as you all know, and there are a whole host of underlying conditions that can increase your risk of a severe outcome from COVID-19. The next slide. And of course, as you all know, our healthcare workers are and have been at great risk because of a lack of personal protective equipment at times, and the kind of jobs that they do. The next slide. So obviously we've needed the vaccine, and extraordinarily, we now have many vaccines in various stages of testing. And as all of you know, We have 2 vaccines that have been approved for use in the United States by the FDA as of December of last year under an emergency use authorization, one by Moderna and one by Pfizer. We fully expect a 3rd vaccine to be approved under a similar mechanism by the end of this month, or excuse me, by the middle of February, if all goes according to plan, a vaccine from Johnson & Johnson, and then perhaps other vaccines after that. The next slide. Well, if you're an epidemiologist, there are all kinds of things you'd like to know about these vaccines, and I've just listed some of them here. And the reality is we know some of these things to a certain extent, and there are a lot of other things on this list that we basically still need to learn. And I'll be happy to talk about those in the Q&A. The next slide. Just to say that normally in the United States, if a company develops a vaccine or a drug after phase 3 testing of efficacy, those data are reviewed in the case of a vaccine by the FDA and the CDC advisory committees, including VRBPAC for the FDA and the ACIP. And once they've approved something, it typically begins use. Governor Newsom several months ago decided that California, like New York, would separately review the safety and efficacy of any COVID vaccine. That's the committee I chair for the governor, and we're joined in our efforts by colleagues from Oregon, Washington, and Nevada. So we now call ourselves the Western State, actually, Workgroup, and we quickly review and put in our 2 cents worth. The next slide. I also served on a National Academy Committee that met over the summer and produced this report at the end of September that was intended to guide allocation of COVID-19 vaccines in the United States, dealing with equity and a host of other problems. I would actually at this point say that this report really hasn't accomplished much and has largely been ignored as the vaccines have been rolled out. But the next slide would just give you an example of the kind of phases we put together of who should get the vaccine first in a time when there would be limited numbers of doses. I think you all know that the ACIP and the CDC have come up with their own approach to this. And then the reality is that each state looks at this and so far has been making its own decisions about who to vaccinate first. There may be some change coming in that area, but that's pretty much the reality, is each state is doing it the way it sees fit. And within a large state like California, there's even diversity among counties with regard to how this is being implemented. I'm technically in phase 1B because of my age, but I don't expect to have access to a vaccine for at least another 6 to 8 weeks. The next slide. Our committee and other committees have struggled with who should come first. Should we focus on the frail elderly who are most likely to die if they get infected? Should we focus on essential workers? How much should equity be a concern in terms of getting vaccine to the poor, to the communities of color at greatest risk of infection? It's a very complicated issue, all the more so when you have half a dozen professional ethicists at the table. And so this has been a complex discussion, and I would argue there isn't one single right answer. The next slide. In our committee work, just to give you one example, the case was made to us that the people who dress up as Santa Claus in department stores should be at the top of the list, because we needed Christmas, we needed Santa, we needed to return to normal, and of course they would be exposed to a lot of people. So the store Santa Clauses should be near the top of the list. Just one group that was lobbying in that way, but many were. The next slide. Once the vaccine arrives, there have been some unfortunate episodes in which people who may not be in the very top groups have nevertheless been vaccinated at various healthcare settings and hospitals, and one could argue about whether that was reasonable or not. But there has been acrimony in various settings. The next slide. We've had lots of questions about whether we should get twice as many people one dose and not worry about the second dose, even though these vaccines were tested and approved in a 2-dose schedule. So lots of discussion about, and I think we're going to hear from Dr. Criqui about alternative ways to get more people vaccinated quickly. But this has been one approach, and the UK, for example, has decided to just get 1 dose into people, and they'll get a second dose whenever they can. The next slide. Some states like Florida have basically said everybody should come on down, everybody over 65, for example, and the result has been pretty much chaos. Long lines of people in picnic chairs with their water bottle and their dinner, waiting 10, 12 hours, often then not getting vaccinated. People spending fruitless time on websites that are crashing because simply the demand of this many people can't be met this quickly. So this has some intuitive appeal, but the reality is in our world, it has produced a number of logistical problems. The next slide. Here's an interesting one. Rhode Island has decided they may pass legislation that they'll punish you and your provider if you cut the line and get vaccinated before it's your turn. I haven't seen this from any other state, but just another example of the complexity of trying to get this done. The next slide. And of course, as you all know, we have a substantial problem with vaccine hesitancy. There are many people who don't want to be vaccinated, who don't trust the vaccine or the government. This is particularly a problem in communities of color, dating back to the problems with syphilis studies in Alabama, Tuskegee studies, and a host of other areas. So we also have a problem dealing with vaccine hesitancy in different communities, but it's not limited to communities of color, and it's quite prevalent actually among healthcare providers who say they don't want to go first because they're worried about the safety of these mRNA vaccines. The next slide. And then, of course, we have interesting claims about the vaccine and its safety. This is the president of Brazil suggesting the vaccine can turn you into an alligator. I know of no evidence for this assertion, but you can understand with the web and all of the nonsense that's on the web why people might be have their fears enhanced. I just read a piece in the New York Times this morning that women who are pregnant or breastfeeding are now seeing claims on the internet that the vaccine can make them, women can either make them sterile so they can't become pregnant or it can affect their fetus or their newborn baby who's breastfeeding, claims for which there are no data. So people are legitimately confused and concerned about these vaccines. The next slide, I'm almost done. And then finally, we have an issue more globally of global justice, as was the case with the pandemic flu in 2009. We basically have rich countries like the United States and Europe basically having ironclad contracts, buy enough vaccine for their populations, and basically leaving the rest of the world pretty much unvaccinated. The Gates Foundation and others have put together something called COVAX, which is intended to raise, actually it's twice this amount, about $35 billion to buy vaccines for poor countries. But they've only raised a limited part of this money so far. And at least under the last administration, the US refused to participate in this activity to try and have some global equity about access to these vaccines as they're rolled out. I assume that the current administration will rethink that. They've certainly been encouraged to. And the next slide. And of course, this may leave countries that are not that poor in the middle. They're not rich enough to buy the vaccines, but they're not poor enough to get this help. And so this will also be a problem. The next slide, I think, is my last slide. So the global pandemic continues to evolve. It has severe economic and other impacts. And Dr. Criqui and others are going to tell us how we can do a better job of vaccinating people. Thank you.
Thank you so much. And we do have some time for questions now. Feel free to put them in the Q&A box. Since there aren't any, I'll start us off with a question. And again, thank you for that overview. You mentioned, the increased mortality amongst minority populations, particularly Latinx and Black and Native American populations? Should race be considered in vaccine allocation?
Well, of course, that's one of the things our little National Academy Committee discussed as the CDC ACIP did. It's extraordinarily controversial. And if you suggest that we should give preference to people of color based on their color for vaccination, it presses a lot of buttons. It gets people extremely irate. So when the ACIP had this discussion, it generated enormous unhappiness in some quarters. So you could argue, and so our committee basically argued it shouldn't be based on race or ethnicity. It should be based on, in essence, social factors, social determinants of health, rather than on race. So that might avoid one problem, but it makes it really hard to operationalize, right? So how do you do that in the real world? It is not so easy. But that's the way people try to get around that great unhappiness about saying we should do it based on race and ethnicity.
Thanks, Art. We have a question from Susan Hansen. What is Japan doing differently than the US that results in their low death rates?
So I think, first of all, for those of you who've traveled in Asia, you'll know, and Japan is part of this, that the culture is really a little different. First of all, mask wearing is quite common to prevent respiratory infections and was before COVID-19. So getting people to wear masks has not been the lift that it's been, or raised the political kickback, if you will, that it has in the United States. So I think they're doing a much better job of masking and of social distancing. But it's not to say the virus is gone or that they don't have clusters, but they've really just been able to control things when there are clusters in a way that fundamentally, by the time people started seriously trying to deal with it in the United States, infection was so widespread that dealing with individual clusters really, I feel, was doomed to failure, frankly. Contact tracing, quarantine, et cetera. I understand why we do it, and it works for TB and syphilis, but once you've got really widespread infection and a lot of asymptomatic transmission, it's really hard. You're muted, I think. Okay.
Yeah, thanks so much. We'll just keep moving forward because I think there's going to be more questions after the next speaker. So let's go ahead and introduce, of course, Dr. Kaplan. Bob Kaplan needs no introduction as one of our technical experts and founding co-leader of the Right Care Initiative. I've had the personal pleasure of working with him through the Center for Excellence in Research, Clinical Excellence Research Center at Stanford, and he has had numerous positions, which you can read there, involved at the NIH and also in health research quality. So why don't we move forward and introduce our new guest, Dr. Criqui, who I also had the pleasure of meeting in Lake Tahoe at the AHA's fellow seminar, 10-day seminar. But Mike Criqui is a very influential investigator in preventive cardiology and epidemiology. He is a full professor of family medicine, epidemiology, and cardiology at UC San Diego. And he and Dr. Kaplan work together closely on some innovative ideas, including that which they're going to talk about today, about some alternative strategies to vaccine allocation. So let's just jump right in.
Sounds good. So I think I'm just going to hand it over to Mike, but let me just begin by saying that Mike Criqui and I have been friends and collaborators for a really long time. I think he came to UCSD probably 38 years ago or something like that. And I had already been there for a couple of years by the time he arrived. So anyway, it's always been a pleasure working with him. Mike called me a while back to talk a little bit about this issue. And some other colleagues at Stanford and I had published an op-ed piece in the Los Angeles Times about whether or not we should vaccinate, or what order we should use to vaccinate people who had already been infected. And Mike suggested that he had an idea that went beyond that. And we published an op-ed about that about 6 weeks ago. In fact, I think it was written a little bit before that. And then since then, we've just gotten more and more interested in this idea, and we have another piece that's just about to come out in the Health Affairs blog. All I can say is that there are many, 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 many copies of it on my computer. It's just been revived so many times that we have version control, but it's just been a great opportunity to work with Mike again. So I think I'm just going to stand out of the way and have Mike give the presentation, and I'll rejoin you for the question and answer period.
So should I share my slides or?
Yes.
Okay.
Jenny can also forward the slides for you if you prefer, but yeah.
Okay. I just put them up. Everybody see them?
Yeah. Yeah, maybe you can just play the slideshow if you want.
Yeah, I can do it here. That's fine. First of all, I want to thank Art. I've known Art for many years. We're both members of a small group called the American Epidemiology Society that meets annually. And I think he did a superb recent overview, including the psychological and the political turmoil that lies behind this this disease. This is the editorial or the op-ed Bob referred to that we published on December 21st in MedPage Today, and it's original basis. We've refined it a lot and brought some new data to it for this new publications coming out in Health Affairs. So to get to herd immunity, there's two pathways to go there. You can either have previous infection or you can inoculate effective vaccine. Either one will work. Obviously, we're using both now. Previous infection goes way ahead of the vaccination rate, as we know. We want to make 2 points in this presentation. Address 2 issues. One is, should persons with prior COVID-19 be immunized? And the second question is, when should the second dose be given? And those are the 2 things we're going to address. So to date, there's actually slides up, maybe the slides 2 or 3 days ago, but now there's over 100 million confirmed COVID-19 cases worldwide. And there've only been 31 documented reinfections. And so you say, well, gee, people reporting documented reinfections, that might be just the tip of the iceberg. So we looked at 2 careful studies, one by Harvey, reported on 3.2 million subjects, who 88.3% had a positive antibody test and 11.6% a negative antibody test, who were followed at 30-day intervals. And they found that the positive antibodies persisted, and there was a 90% reduction in COVID risk over 90 days. And Lumley et al. Showed a similar 90% reduced risk in 112,000 healthcare workers in the UK. In the latter study, there were 1,177 workers who were seropositive at baseline. Only 2 of those became PCR positive, and both remained asymptomatic. So this is kind of very similar to, I think, equal to the vaccine. The vaccine efficacy is said to be 95%. Roughly for both the Moderna and the Pfizer vaccine, but neither one of those trials did they assess. They didn't test anybody for COVID. They just, when people actually got sick, then they went to their doctors and they got a COVID diagnosis, but they didn't screen people on a regular basis with a PCR test. And so I think if you look at the efficacy of having been affected and the efficacy of having received the vaccine, probably the prior infection is a little bit better, but they're both efficacies of above 95%. Considering these people were followed very carefully in these 2 studies. So the latest thing on this issue is Dr. Fauci stated about 3 weeks ago that people infected with the coronavirus need to wait 90 days for the vaccine. And he had some microbiological, virological rationale for that, which he did not provide, but maybe Art can help us with that one, but suggesting there was a potential danger. And so what's actually being done in the real world, I know, is that people come in and they get a vaccine. They drive in a car in a big parking lot, or so no one asks if you had COVID-19, and no one draws an antibody level. They just give you the vaccine when it's your turn. And so this really isn't being considered in practice, at least at the moment. Joe Biden promised 100 million doses in the first 100 days. This morning on television, he was talking about maybe a few more doses than that. But so what could you do with 100 million doses of vaccine? On day 1, or you could offer a high level of protection to 50 million people with 2 doses, or you could offer what appears to be very good protection to 100 million people with 1 dose, followed by a second dose 90 days later. If you space this interval out to 90 days, which the UK has already done, and Germany and Denmark are discussing, you provide a lot of freedom in the system to ramp production up and get the vaccines out to people. So when should the booster dose be given? We suggest it should be 90 days. We did that about at a similar time. We first suggested that the UK decided to do it. Dr. Fauci doesn't agree with that. You may remember that he went on television several times saying, oh no, we have a dosing schedule. And he said, well, we're talking about when to get the second dose. And that went on for about a week. And then he said, well, we talked about it, and we only have randomized controlled data from doses 3 weeks apart for the Pfizer and 4 weeks apart for the Moderna. And so we're going to go with that. And Dr. Offit has been interviewed on TV, Paul Offit, and he agrees. As I said before, the UK National Health Service agrees with us. And just recently, January 22nd, last Friday, the CDC suggested the second dose can be delayed up to 6 weeks. And I'm not sure about the deliberations that went on with that, whether that was from the ACIP or where that suggestion came from. But that's the latest on that issue. So one of the reasons that we want to talk about the second dose and when it should be given is this. Bob just made this slide yesterday. This is the schedule of Stanford, which has got a pretty big medical operation. And on the 24th of January, which was Sunday, they were giving Moderna dose number 1 and Pfizer dose number 2. And every other day in the month going through the 18th of February, the only available second doses. So if you need a first dose, no matter what your priority is, doesn't make a difference. The people who had a first dose got to get their second dose. They're in line. They've been scheduled. These are either 21 days apart for Pfizer or 28 days for Moderna, and they have the spot. And there's no other spots. I'm not sure why Stanford's closed all those days, but maybe that's some kind of break or something. But that's the situation. I can tell you UCSD, I know the data very well. I work with people here, and we're giving 500 doses a day. There are 2 clinics downtown at Hillcrest Hospital and in La Jolla at the Jacobs Hospital. We have 2,900 doses as of 3 or 4 days ago. We had 2,900 doses left and no more doses coming for 2 weeks. So I think we're going to run out before we get more doses at UCSD. So the argument in favor of maintaining the 3-week or 4-week schedule is that in theory, RNA vaccines require 2 doses to achieve durable immunity. That interval was never tested in trials. There was no longer interval tested. There was no single dose tested. And so it was a judgment based on the antibody response that they were getting with the first and second dose, that this would be the best way to immunize someone. But the arguments against it are maintaining this very tight schedule, which ties up doses. In fact, as you know, there was political argument about people were holding back the second doses and they had to release them. And Joe Biden said, you got to release them. And then they went to look for them. They said, we don't have them. They're at the company and so on. So I don't have any insight on that particular issue. I don't know who's telling the truth, but we do know from phase 1 studies of both these vaccines that the antibody response to a single dose is almost identical to complement plasma. And natural infection shows prolonged immunity. So proponents of the strict adherence to the 2-dose schedule point to estimates that the first dose is only about 50% effective preventing COVID-19 infections. That's true if you take the first day that you received the vaccine up until 28 days. But in fact, it takes a while to develop the antibodies. And those analyses saying it's only 50% effective or 60% effective for Moderna and for Pfizer exclude the 14-day post-inoculation period. And those are when the neutralizing antibodies are being established. And so we took a close look at the data, which is in the New England Journal of Medicine paper, and it showed that the first dose was 94% effective for the interval 15 to 30 days after the first injection. Exactly the same efficacy as for the period following the second dose. And I'll show you that data here. So many of you have seen this graph. It shows the dramatic effect in this particular case of the Moderna vaccine. You see the dramatic substitute in the placebo, and you see the mRNA with very few cases accumulating, and you see the 0 point, and the graphs don't start to diverge, not at 30 days or after the second vaccine. They diverge very early, right around 12 or 14 days. So if you look down to the table below, you can see in the placebo group, 14 days after dose 1 to dose 2. That is only 1 dose, but in fact, you have had 14 days to develop antibodies. There was 2 cases in the vaccine group and 35 in the placebo group. That 17.5 ratio is identical, 95% efficacy, as it was to the entire trial. So as far as we know, your optimal efficacy had already been achieved with 1 dose by 14 days. Now I realize we don't know how long that lasts, and that is a question, but we're extrapolating from, let me just go back for a second. We're extrapolating from the natural infection data, which have exactly the same level of neutralizing antibodies. And we showed you data for over 6 months, and there's new papers out now, one in Nature and another one. One says 6 months and one says eight months, that there's durable immunity from a single COVID-19 infection for the vast majority of people who've been infected. And if the antibody levels are the same with the vaccine and you're using the same antigen, it would make sense that you would have continuing immunity. The interval between doses has not been studied, as we said. It has been studied, I'm sorry, it wasn't studied in the Moderna and the Pfizer trial, but in the Astrozenica trial, they showed delaying the second dose results in more immunity. And just in the last 2 or 3 days, a Brazilian study with the Sinovac biotech vaccine, which only has 50% efficacy overall, so it's not terribly strong, but it's 20% more effective than a subgroup of patients who waited longer for their booster dose. And so in our test to this, there's evidence from other vaccine trials that the durability and the immunity is stronger with wider intervals between doses. Many vaccines, as you know, we give on an annual basis or over several years. This is the data from the AstraZeneca trial, and you can see that vaccine efficacy is not great, as you know from AstraZeneca, and it may not even, I don't know, my guess is from what I heard this morning is that AstraZeneca may not be really approved in the United States, because apparently a breakdown of the data shows it really doesn't work very well in older people. And so the 70% overall applies to everybody. But this shows that in the circled part, that at less than 6 weeks between vaccine doses is 53% efficacy, and it jumps up to 65% if you had more than 6 weeks between vaccine doses. And that second estimate was statistically significant. The confidence interval excluded 0 effect, whereas after with less than 6 weeks, the confidence interval included no efficacy at all. So the change in the CDC guidance last Friday was, and again, I don't know exactly why they decided this, but the second dose should be administered as close to the recommended interval as possible. However, it's not feasible to adhere to the interval. Then you can go up to 42 days after the first dose. And again, they don't have any data on waiting for 42 days, no more than they have any data on waiting for 90 days or any other number. And this is, unfortunately, in a pandemic with this urgency, these kind of guesses will have to be made. So we made our guesses, said, well, how much good would it do to delay the second dose? And we're talking about 90 days. And the assumption here, by the way, is that by 90 days, which is 3 months, the US will have, under strong leadership, produced enough doses that this will not be an issue of getting your second dose after 90 days. So if you take now, currently there's about 200,000 cases of COVID-19 per day. A 95% vaccine efficacy would prevent 2.63 million persons from getting COVID. However, you could immunize 100 million persons with 1 dose, okay, excluding persons with prior COVID-19. Under this strategy, you'd get 5.85 million persons avoiding COVID-19. So the difference is 3.22 million persons would avoid infection compared to the standard strategy. That is, if you immunize 50 million people with 2 doses versus 100 million people with 1 dose, you prevent 3.22 million cases. And what would that translate to? So this is a tough statistic to find, but I did a lot of work to find it. About 15% of all COVID-19 patients are hospitalized, and about 1.7% die from the disease. You'll recognize that means that the hospital case fatality rate is about 10, 11%, and that's very consistent across the country now. It was worse in the beginning. So the alternative strategy, using these multiples, the alternative strategy of delaying the second dose could prevent 480,000 hospitalized cases and 54,400 deaths by April 30th. Now, is saving that many people from going to the hospital and saving that many people from dying worth taking the chance that a second dose with good levels, a first dose with good antibodies from the first dose will last for 3 months? And, you know, I'm a clinician, I'm a licensed physician. My guess is that that is a much more rational strategy to try and prevent hospitalization and death. You know, I've tried this out, and my oldest son's a doctor, and some of his friends are physicians and tried it out. And they all agree that if you ask somebody to say, you know, what's the best strategy to prevent it, considering everything we know, anybody who's going to bet money on it would bet that it would be a better strategy to delay the second dose, that you'd save, these numbers are approximations, but you'd save a lot of people from being hospitalized and a lot of people from dying. So the bottom line in 2 bullet points is considering limited vaccine availability. In the short term, there is little benefit from vaccinating either people with a prior infection or those who have already had a first dose. That's again the short term. And 2, using the limited supply for these 2 groups would cause harm by depriving fully vulnerable persons of needed protection. And that's it. And I think we're happy to take questions.
Thanks so much. This is very hot off the press with the changing guidelines and the implementation of this in the UK. I know we all have a lot of questions on our minds. I'm actually going to ask Dr. Zelikoff to unmute. He had a question similar to what many of us may be thinking about antibodies. And Dr. Zelikoff?
Thank you. Thank you, Dr. Criqui. The question is simply this. We're measuring neutralizing antibodies, which is perhaps because it's relatively easy to do, but that is, of course, just a surrogate for some overall global immune response. And I'm wondering if there's any data with regard to the extant vaccines of other measures of cell-mediated immunity, for example, cytotoxic T cells, whatever. And the reason that I'm really asking is that we've already started to see some data that has people worried, perhaps not justifiably, that with the novel strains that are starting to appear, that neutralizing antibody as a measure of of immunity shows that there might be less value to the neutralizing antibodies per se. So I'm wondering if there's any data on other measures of immunity, particularly cell-mediated immunity. Thank you very much for taking my question.
Yes, both Pfizer and Moderna have published their data on T cell activation and CD4 and CD8 levels, as well as the Th1 distribution of T cells. And both the vaccines do produce immunity, cellular immunity, as well as humoral immunity. Now, the question of the variants is a very good one. The very latest data is Moderna has actually used neutralizing antibodies from both the British variant, the UK variant, and the South African variant. The South African variant, the British UK variant, which is becoming prevalent in the US, was no problem. The antibodies from the vaccine were equally effective. The South African variant was a problem. There was an 85% reduction in the antibody neutralization, but according to Moderna, it's still high enough to prevent infection, even though it's 85% reduced. So I find those statements a little kind of hard, but that's the latest data on that. There are another variant that just came out of Brazil that's brand new that people don't know. It looks like it's got some of the same configuration as the South African variant. That's a concern. But you know, these are empirical questions, and we're glad to know that Moderna is already developing what they're calling a booster vaccine that will provide full coverage of the South African variant, potentially, I guess, the Brazil variant. And they are talking about using that as a third or second booster dose or a third shot.
And we don't have any cell-mediated, any of the cytotoxic T cell Th1 cells, for example, with regard to the new viruses?
Not that I have not seen any such data. One would
Okay.
expect infections in general produce both, humoral and cellular immunity. I think that would probably be logical, but I have not seen any data on that. No.
Okay. Thank you very much.
We have a question from Dana Miller Martinez about, like for example, at Stanford and other places, there are policies not to vaccinate someone who's had COVID within 90 days. But what about vaccination for people who have had COVID more than 90 days ago? Would you recommend vaccination for them? And I'll add on my part of that to that question is there any role for antibody testing for the practical, everyday use?
Yeah, so those are really good questions. In my judgment, seeing very good evidence of humoral immunity at 6 and 8 months, I think that I would put those people at the end of the line. Nobody's really gone on. This pandemic has only been with us for 11 months. So no one's really got anything longer than 6 or 8 months of follow-up. We don't know if it lasts for 5 years or 1 year or 8 months. We're pretty sure it lasts 8 months. So I would put the people with prior COVID at the end of the line. Would I screen people? No, I wouldn't, because drawing antibodies in the clinic, getting them back, it's one of the real problems at the micro level is getting just the number of people involved, and nurses and so on, to get people vaccinated. And the logistics of it, if you add a logistic, we have to come in and have antibodies drawn to exclude something that's probably a tenth of the population. It's just not, I don't think it's cost effective. So I would suggest that we ignore prior antibodies. Say, why are you taking a risk? Maybe they just had COVID. Well, there were 300 and something people in the Pfizer trial and 500 in the Moderna trial in the vaccine arm that had evidence of prior COVID at baseline, and they didn't suffer any harm. So I don't think I would worry about harm, but I would also not think that they need it for 6 to 8 months, and therefore we get doses after pretty much everybody else got doses.
Thanks. Dr. Reingold, do you want to comment on what we're talking about, either the delayed dosing as per the recommendation, or even what Mike Criqui is mentioning about delaying it even further?
Well, I think Mike did a terrific job laying out the issues. So, I think first of all, I certainly agree with him that serologic testing before deciding whom to vaccinate is a non-starter in the real world, frankly. I just can't see it logistically or from a cost point of view. So I agree with that. I would say that there are Paul Offit and Tony Fauci are not the only people who basically are concerned about switching to a vaccine schedule that is really untested or didn't come from the clinical trials. That's their basic argument. I think the other argument that people put forward is that if a single dose is not as effective as 2 doses, you may have quite a few people in the community who are not as protected as they think. They may suffer infections because of incomplete immunity, and particularly if they stop wearing a mask and social distancing and doing other things because they believe themselves to be protected, that could have undesirable consequences. Now, I understand Mike's data or presentation is intended to basically show that the people who got 1 dose are pretty much fully protected, and that the efficacy is no different than 2 doses. But I think that would be a subject of intense discussion. But I think I think it's an elegant presentation, and in terms of lives saved and all of that, and obviously the Brits and others have decided that's the approach they're going to take. So I do think it's defensible.
Bob, do you want to have anything to add to this?
Oh, so I'll give another opinion on the antibody issue, and I think the reason it's worthy of discussion is that there are presumably a lot of people out there who have been infected but don't have a positive PCR test. And Mike and I have gone back and forth about this. So some estimates are as high as 8 to 10 to 1, and others are lower. And it probably is so that early in the pandemic, then the ratio was higher because the testing was less available. So as testing has become more available, more people have the opportunity to get a PCR test. But under any estimate, there are just a lot of people out there that are antibody positive and presumably immune. So if you have very limited supply of vaccine, maybe it does make sense. And so maybe we'll put that out there for discussion.
That might be a good time to actually transition to EDU, right? The concerns that were raised were really about the practicality of implementing this in the front line and the costs and how you're going to actually make this vaccine distribution happen. And that's exactly why we have EDU here. I could just go ahead and introduce Ed, unless Bob, do you want to, are you?
Go ahead.
Okay, so again, EDU is also here. He is the Chief Quality Officer for Palo Medical Foundation and also one of our leaders in the University of Best Practices here for the Right Care Initiative. We value his opinions as himself a practicing clinician on the front line, but also in his expertise for quality. So with that hat, I'm going to turn it over to Edu to talk about the real life implementation of this COVID vaccine rollout.
All right. Well, thank you, Nerali. A sound check. You can hear me okay?
Yeah, it sounds great.
Perfect. So it's very interesting to me because giving this talk today, because I distinctly remember 5 weeks ago, literally the same time, I was in a Zoom call with our organization to say what to do with this COVID vaccine. So if you heard the previous talks, is imagine all those changing landscape and opinions. How do you implement this? So what I'm going to be talking to you is giving you our story that we did at Palo Medical Foundation. And I structured the talk with some 10 key points to think about. And I think when you hear this, I want you to think about this at this with everybody's best intention. At the end of the day, it's shots in arms. How much do we need to debate these issues versus we should plunge ahead and get as many people vaccinated as quickly? And also the patient reaction and the emotions involved with it, which was one of the aspects that we have learned to be one of the biggest issues that we have to manage. And how do we communicate that? So again, 5 weeks ago, the vaccines came, and this is the picture that we were already elated. Now it's what do we do with it? Next slide. We knew when we came, we got to do this quickly. This came right before Christmas time. And in fact, in our organization, we had planned the vaccine. We were told the vaccine was going to come between Christmas and New Year's. And we have been setting it up for the infrastructure to support that during that time. So one of the points is just that we should not be, while we were happy we got the vaccine 1 week early, the fact that it came as a total surprise to us should not happen. We should know that this is happening. So that's one of the challenges that we are facing is just that the efforts about vaccine supply, when it comes, it still needs work to do because at that time it was not coordinated and we literally did not know. And it just came and was delivered to our operations officer's desk and said, oh, what is this? Oh, it's a Moderna vaccine. So when it came, there was a debate whether we should hold on to this and put the infrastructure together. But here's the part of the emotion part that came in. The fact that if the word got out that Pam got the vaccine and waited until after Christmas to give her the first dose, there'd be pitchforks in front of our leaders' homes and their heads would be awake. So that was quickly decided that there's no way, we got to go ahead. So within a day, we gave the first vaccine, okay? Next slide. Now, immediately issues came up. So there's equity issues. Now, PAMF is a large organization that spans 4 counties with offices in over 40 locations. One of the debates that we had is that, oh, well, let's do this fast, let's do this quick, let's just do it at one place and have everybody travel there. Well, there was a counter opinion is that, then if you do that, for those people who this vaccine happened to be delivered to our Palo Alto campus, then how would it look like to our physicians and staff who are for Palo Alto, we just walk down the stairs to our vaccine center versus our colleagues who are in Dublin and Livermore or in a campus in Watsonville that have to drive an hour to come in to get that. then one of the first questions that we were debating is that do we hold into one site and have people to travel while we have time to set up for us to set the other sites? Well, this is where the way how we organize in our geography came into play, where everybody was passionate. So you can go to the next slide. The decision was made that no, let's have the vaccine travel. We'll learn how to transfer that vaccine in a safe way. Going to set it up, and at that time we started with 4 locations that opened up literally on Christmas Eve to give the first vaccines. So we had that forefront in mind, and this theme about equity will come up several times in our talks of how to deliver it. And like those of us in the health system side, we really know how to deliver a vaccine. That's not complicated. It's the rest of the stuff to figure out the supply chain issues. How do you segment the populations? How to tee it up when the whole world wants it on day one? That's what the challenge is. Next slide. So this came up. All right. We know we're in Tier 1A. We are the healthcare workers for the front lines. But again, we have 1,600 physicians, and that 4,900 staff. There's only 10 people that can be the first. How do you choose? And in fact, how to segment the healthcare workers, departments plus department, who are the first to go? By how many in that code you want to do? The issue came up in the vaccine. All right, how do we split it between staff and physicians? There are more than the physicians. Do we do a 3-to-1? Well, doing 50-50 split just because do you want to spend, how to decide on tiers and priorities when these things change a lot? Well, that consumed quite a bit of time. And in fact, if you look at it at a macroscopic level, that is essentially the debate that's happening among these patients. Who should go first? Essential workers versus age? How do you factor social determinants of health into this? And we're spending a lot of time spending a lot of that, where in reality that if we do this quickly, shots in arms, then we can spend less time doing this. And that is indeed kind of where we go. So you know what, let's just go with who is available, who can get there, because this is Christmas time. Who's in house, who's willing to come? We'll go with them first. Next slide. So this is just a screenshot of the first bundle of physicians and staff that got it. And then what ended up happening is that as we started with this, we just say that, hey, we started the first day, we only gave out 50 doses because we're setting it up. Then the next day we went up to, then we had 4 locations, so we quadrupled the amount. And over the weekends when we did it, we were able to scale it up. So we rapidly kind of go through it. And at that time, the concern is, all right, how many doses can we give? Next slide. So this is the debate that we just had earlier. We got 3,000 doses. That was the first cohort. Then we had a debate. Is this for 1,500 people, or was it for 3,000 people? Right, first, second dose. That debate we had before. At the time, our CEO was very adamant that we need to do it in a series, that if you need to do a 2-dose series, so we got to hoard the second dose. So it was 1,500. There was a lot of pushback from our organization that, hey, we got physicians and staff combined close to 7,000 people. We really should get everyone their first dose as soon as possible. Okay. Now, while that debate was happening, we decided that, hey, let's just get the first 1,500 out first, and we're worried about do we second dose, first dose later. So fortunate for us, when that happened, our second batch came in a week later, just as we were trying to get this issue settled. So at that time, so this is 4 weeks ago, vaccine supply was not an issue. And then our mission at that time was vaccinate quickly, vaccinate maximally. You can go to the next slide. And that was the theme. You know, let's just vaccinate as many people as possible, assuming the vaccine supply will be there. And that has been the case for us for the first 3 weeks of this journey. Okay, next slide. Then the issue then came, and this gets to the space issue, which I want to share with you about, is how do we do this safely? Recall, we're still in a pandemic. There's need for social distancing. So do we have the space to do so? You kind of know the story now. We're all doing mass vaccine centers, which we'll get to in a moment. And then the other thing is just that we all have our processes to give the vaccine. In fact, we follow the package insert for the Moderna vaccine. There are certain steps that the CDC wants us to do. So there's a workflow piece, we put it together. And then if the goal is to vaccinate maximally, then we're going to think about how, from a throughput standpoint, can we move these things through quickly so that we can use the same amount of resource to run through as many people as possible in a safe way. So that came up, and that took quite a bit of time to kind of figure it out. So next few slides, I'll just show you some visuals of our vaccine center. So this one, it happened in Mountain View, and it opened up right over New Year's Eve weekend. This is an indoor vaccine site. Next slide. So you can see us spacing out our vaccine stations far apart. This, we took over our conference center to do that. Next slide was a close-up of one of the stations. At the time when we started up with this, we had, as you know, Moderna bottle is 10 doses in each vial, and you draw up 0.5 cc's to inject. So at the point we kind of followed it, we at that point did not know whether you were able to pre-draw the vaccines ahead of time. Turns out that we could. So when we first started, it was a 15-minute stop at the station to do the vaccine draw up and the process of injecting. So I say, hey, if each station has to do 4 an hour, we're never going to get there. So how, and this is where we use our lean consultants kind of think about throughput. How can we take out the waste in the steps, minimize those handoffs, kind of move people through quicker? And now we're at a point where we're able to vaccinate the person every 3 minutes with the goal of hopefully going down to every 1 minute per station. So each person here will vaccinate 60 people as opposed to 4. That's our aspirational goal to get there. And then that's kind of what we're hoping for. Next slide. There's a need for patients to be observed for 15 minutes. That's a safety check we want to build into this. So just a visual of how we set it up in a social distancing space. Now at the beginning, when we had 15 minutes for them to inject, 15 minutes at the wait station, that worked fine. But then as that accelerated, where they're running through patients every 5 minutes, suddenly then the bottleneck became the waiting area. And it became very clear after the weekend is that there's just no way we're able to do this at our own facilities. We got to go elsewhere to do this. We just simply need more space. So next slide. But quickly to show you, and I should pause over here to mention about that. And for those of you who got your first vaccine, you probably recall the emotions that you felt that, hey, finally, you know, we have a way out of this. And remember, this happened to us right around Christmas time. So when this happened, it was as if you gave the beautiful Christmas gift to the staff and the physicians. Because literally, we gave our first New Year's Eve to the bigger group. And the emotions and elations that happened were just incredible. Now, on the counterpart, we also got a lot of frantic emotions on people who did not get, were further down the tier to get them, that they were hearing their colleagues getting it and they had to wait. The anxieties and the frustrations, and frankly, there were many stories about, and I'm not afraid of sharing with you all, physicians just makes the worst patients, and an anxious physicians is the worst of the worst. That I was the one that had to approve each doctors to get the vaccine at the time. So yeah, it was incredible, the petitions I got from my colleagues and the emotions behind that. And that part made a job an additional level of complexity that I had not anticipated. But that was very helpful for us to know, because we're seeing exactly that happening with our patient vaccines. And that's helping us a little bit of how to mitigate that. Next. So sharing with you, and this is our first mass vaccine center. This is set up as a drive-through station of how we do so. Next slide. So the patient drives up. Oh, okay, this is a visual of us now that we were able to now go to pre-drawn syringes. As you know, the Moderna, once you draw it up, it expires. It has to get in an arm within 6 hours. Otherwise, per package insert is deemed ineffective. So had to put in a process of counting and tracking inventory on a location basis to make sure that people that show up rounded to 10 was another operational thing we had to do. So next slide. So in this picture, you can show someone here, the nurse giving the shot to the patient who is in the car. So they don't have to leave in a socially distant, compliant way. Next slide. And then they wait in their waiting area for 15 minutes before they go. And then we have clinical people run down the hall to kind of monitor them in that way. So that's kind of our setup. Now, when we put this up, I looked at this and I thought, you're presuming that you have to have a car to come to the site. So again, the equity issues came up about, now how would someone that doesn't have a car, how would they come here? If someone came up on a bike, how will we accommodate that? Well, as you know, we also have the in-person back centers as an alternative way to get there. But these issues are coming up. And also, this is in Santa Cruz, so the demographics are a little bit different. If you go back to our Mountain View Center, if you look at the patients who showed up there in our first wave, I'm not afraid to tell you is that they are no way reflective of the demographics of the community I serve. And this will be a theme that will come up in my talk about. That's one of the challenges that I'm very mindful of, is just that we already see the disparities of our patients suffering adverse outcomes from COVID. You know, shame on us if in the vaccine delivery part we do it in a way that exacerbate that. We cannot tolerate that. And a lot of our current efforts now is to find ways to mitigate for that. Next slide. Just a slide that we have paramedics on site to show, to monitor for anaphylactic reactions. This is one of the requirements if you do vaccination on an offsite campus. Next slide. All right, here is now, so we opened up for patient vaccines about 3 weeks ago, because once the clinicians and staff started to get vaccinated and our vaccine supply was adequate enough, then our organization said, we need to get pushing for it. Now recall, Palo Medical Foundation is a outpatient only facility in our county. So we did not have a partnering hospital that got the vaccine. So we got it basically a couple weeks later than everybody else. But we felt very committed that we need to go out and give it to our patients. Now, at the time when we were setting it up, it's all right, we are going to do healthcare professionals who are our patients. Then we want to go to phase 1B. And at that time, there were essential workers, there were patients, age-based, and just for sake of simplicity, and given that there were permission that each healthcare organization decide what they do, we just simply decided just do what's easy. And we started with county residents ages 75 and older. We know who they are. That's a field in our EMR. We know who to outreach to. Boom, that's where we started. Now, the challenge is just that there is every health system moves at a different pace. And in fact, some of our partners are able to move faster. And that became an issue because, as you see over here in this visual, when I pulled this from yesterday, Stanford's vaccinating ages 65 and earlier, and I think Kaiser just started it just today as well. We are still doing ages 75 and older. Then what happened was it was challenging in our patients because they were not the only sources to get the information. They heard, well, Gavin Newsom said 65 and older were eligible. Why aren't you doing so, Pam? Then we had to spend time kind of explaining to the patients about this, right? And then you know, this came to the point where the patients were like shopping and going around other places to get the vaccine because some places have not started patient vaccines yet. So we have patients coming to our site that, well, I'm not a PAM patient, but I heard that you're supposed to vaccinate everybody. So can you give me the vaccine? You know, then we had to figure out that workflow and all that. And at the point when we designed this, we had made an assumption. Of course, you should never assume that since we're setting up now at this time, we had 6 vaccine centers that were going to address our local community only. And we had planned it that way. but by far there was a much larger percentage of our patients coming to us outside of our core geography that we had not anticipated, which is good. We want to address, we treat our patient as a whole, that's one. But what happened was that our vaccine allocation within PAMP was predicated on the active patient lists of the county. And now that we have to adjust that to take into account that, hey, we have to look at it at a different way, because in reality, patients are traveling long distances. They're willing to do so to get the vaccine. So from an equity standpoint, we have to adjust our vaccine allocation within organization to our 6 centers in a way to take that into account. Next slide. So when we opened up our vaccine on January 14th, our website crashed. I kind of figured out that it would have happened. And mind you, it was a soft launch for us because we have not started proactive patient communication until 3 days later, because we want to test this out. But in our geography, we have 300,000 patients 75 and older, okay? When the call center, the web center stand up, they actually increase, they said, we kind of move 100 other people in our call center to answer those calls. But I figured out on the physicians and the staff side, we realized that probably up to about 20% of your patients will be the early adopters, so to speak. They are the ones that are ready and will do anything to get the vaccine, and nothing's going to get in their way. So I kind of figured that there's no way that this thing is not going to crash, because when you have 300,000 people, and even if it's soft launch, now with social media going on, word just gets out. PAMP is starting to vaccinate patients. Let's all get our first appointment. You know, the rest of the story you already know. And we're not the only one. You know, Kaiser also had people waiting up 4 to 6 hours to get through the phone lines. And this is just a soft launch. There's just no way about that. And we kind of knew that because from the staff and physician side, we saw that happening. And that kind of really drove up our solution to this. There's no way we can staff this to get out of it. We just need to open up as many slots as we can so that people get the appointment. That's kind of what they want. They want a secure appointment for them to get the appointment to address this. And that has been our effort, is standing up these mass vaccine centers and open up the schedule to as many slots as we can. Next slide. Then we're dealing with the issue about changing guidelines, which previous speakers has mentioned. And the biggest one that we had to face with is this vaccine interval. And if you look at the CDC, of course, they had just updated a few days ago, but prior to them, it was written in a way where it really wanted you, and this is the Moderna, so just focus on that one, because that's the only vaccine we're delivering as of right now. You really need to get it as close to the 28th day as possible. Now, these are clinicians and staff, so they got it over the holiday weekend. Now, exactly 28 days afterwards, they may be on call. They may have clinical duties of which it makes it hard for them to do so. Or maybe one of them had a more severe reaction that they wanted a day of rest before returning to their clinical work. And we had a huge debate about how much to adhere to that 20-day goal versus to flex beyond it, either a few days early, a few days later. And you're talking to clinicians who want to follow evidence-based guidelines and the science behind that. Whereas when I was kind of guiding this, it's just that, you know, folks, ideally you want to get it exactly 28 days. But the realities of the ground is that we need some flexibility here and the ability to have more options, because in real life, in the way, so that while the CDC, while the guidelines at that time did not recommend you to schedule the follow-up dose within a time window, at that time they wanted to do it a 28th day, we just mentioned that as long as at that time the CDC says a second dose counts, whether you got it up to 4 days earlier, we were going to permit that and not get in the way. So these debates about how do you incorporate these changes into your operational workflow, how do you cascade it into a guide, kind of a standard workflow, then have all these vaccine sites to do it quickly and efficiently, is something that we know how to do well. But when these things change quite frequently, it has been a challenge. Next slide. Now we're standing up many vaccine centers. Now, for the past week or so, we're running into supply of vaccine issues. And this is our biggest worry, because go big or go home is the mission. And this gets back to our question that we had earlier in a talk, whether should we concentrate on giving people the first vaccine, or do we want to adhere to the 2 vaccine doses? Now, if CDC says you can go up to 42 days, now do we now adjust that so that, again, our concept has been maximize as many people as quickly get that first shot in the arms? Now, do we then flex our guidelines to maybe then to default the schedule further out? Right now, we're still doing automatic scheduling at the 28th day. Who's going to make that call? How to adjudicate that? CDC says yes. Do we on our own decide to do so? Should we decide this together as a community? And I think that has been one of the challenges about these decision making, about prioritizing of patients, pacing how quickly you go through, that we're really having each system making their own decisions that oftentimes are not going to be the same. Do these differences matter? And then when the patients see this, they're just getting confused to say, oh, do I need to repeat that vaccine? This is scheduled at 6 weeks. That must be a mistake. Let me call back and reschedule it and all that. And that has been a big challenge. Next slide. So it gets to the communication challenges I want to talk about. It has been quite challenging to figure out how to, what to post, how to communicate, and in particular for our call center staff who have to answer these questions, and also for our staff and physicians who, when they can't get through to the vaccine call center, what are they going to do? They're going to call their clinician offices to handle this and some of the frantic behaviors and the emotions that we have, in a way that one day the talking points are changed from the different day. So it has been quite challenging in that fact. And I think that is one of the things where Sutter Pampa make a decision, but the day before the state may come with a different message, and then the CDC comes in with a change in the guidelines. It comes to the point about who are we should be listening to, and how do we do that in a way that we still have the credibility, because we know vaccine hesitancy is out there. And again, not afraid to share that within our organization, we have countered that as well. So, hey, I am just going to wait and let this settle. So how do you try to both balance the need to go fast, adjust to these changing talking points in a way that you outreach those who are also willing, but also reach out to those who are hesitant in a way that it gets to where we need to do? We're still learning of how to do that. Next slide. So finally, I want to end on these few points about the equity. Again, I mentioned that that is one of the issues that we face. And then right now, when the quickest way to reach the most people, you use technology. It's quicker for patients to self-schedule on the portal than they have each and every 3,000 of them call us and manually to do so. However, to do that, you're presuming that the patients you have has internet access, has the technical savvy to navigate our portal, which, by the way, predominantly is in English right now, that has the patience to work us through. We know, again, we set it up quickly. That's where we're going to start out with. We know we are intentionally disenfranchising those who are not technology enabled. Again, if you can't go to the website, you're going to call. But again, the call takes hours to get there sometimes. Our now call center is answering within 20 minutes, better than 4 hours when we started out with, but still, you're thinking that person has time to sit on the phone and wait to answer for 20 minutes or so. So how do we remove these barriers to the extent they can so that we don't disenfranchise that population? Next slide. So again, this has been in the headlines. So again, this came out just over the weekend about addressing how do we prioritize vulnerable communities. And I picked this up as an example about how do you make this in reality. So it's well intended. So here, CDPH wants us to look at the California Healthy Place Index and look at where the disease burden is highest and target those communities, which I think is a great idea. Next slide. So here's a visual of that in Santa Clara County. And these are the 3 census tracts that came out. However, how easy is this for us to do so? Because our current databases don't have census tract in there. Again, we may be able to use some proxies to do so. But again, I think this is one of the operational challenges that while we have real intentions to follow state guidelines of how do we do so, it runs into the reality of the operational challenge. How much time are we going to drill into reconfiguring our databases to accurately capture that, to report out for us to do the outreach? Versus, next slide, some of the things you kind of just go and do. So this came out from Los Angeles, where they made a decision at USC and said, hey, housekeeper staff, our frontline workers, let's vaccinate them. Hey, why don't we just go ahead and prioritize vaccinating their household members who are 65 and older, right? Because they're there and all that. So these are the type of examples that I think we need on the ground so that we can rapidly get shots in arms in the target communities that we want. The more time that we have to invest in setting up infrastructure, databases, designing new workflows to reach out is delaying us to get to shots in arms as quickly as we can. Next slide. So finally, I want to end over here and open for questions. These are current things that we're thinking of doing at PAMPN, et cetera. So again, objective number 1, we are launching our next mass vaccine site in Santa Clara County this week. And within the next 2 to 3 weeks, we'll be launching them in Santa Clara County and as well in Alameda County as well. So each of the 4 major counties we have will have these mass vaccine centers that will be able to have enough throughput to meet our patients' needs, assuming the vaccine supply is robust. We have mobile vans that are now in hiatus because we use it for community outreach for in-person visits, but we're thinking about repurposing them to use it for patients that can't get to us. We're still trying to, just had a call today trying to figure that part out. And then I think we have the obligation to partner with our community organizations because they know where our vulnerable patients are. And then we should partner with them to do targeted outreach and communication to them. And perhaps once we have a workflow and a vaccine delivery mechanism, perhaps it is the mobile van, that we can go out there and do that. We also want to make sure that we have clinicians and staff willing to do anything they can to help meet the patient needs. So we're thinking right now about standing up, once the vaccine supply gets more robust, to stand up a kind of a vaccine quote unquote concierge service devoted specifically to our at-risk populations so that we don't have them to navigate through. We're proactively to contact them and say, hey, it's your turn now. You should come in. Let me get you an appointment within the next 2 days, for instance. So those are things that we're going to do. And finally, I'm a kind of a data person. I do feel that we are going to take we're now reporting who gets vaccinated, who gets first dose and second dose, as the state wants us to do. We have the database of our patients, and we want to stand up looking at that and then segment to our vulnerable populations and see how we do at our priority populations. And we see there are gaps in there, then to adjust our outreach efforts to target those communities so that our vaccine efforts close the disparities instead of expanding them. So that's my last slide. On that note, I'd be happy to open up for questions and engage in a vigorous discussion about how we get us through and end this pandemic. Thank you.
Thank you, Ed. You actually posed a lot of questions that the other panelists may want to comment on now. My question is really, you know, so much of what you asked, I wondered, and you even asked, who is responsible for deciding this? What amount of detail needed to be happening at the state or federal level, and how much is now happening at the local level? Should it have been a different balance? Would that have made your life easier or harder?
Yeah, well, I'll just say, and then I'll open it up over here. It was helpful for us when the state decided just yesterday that right now, it seems like they're prioritizing age-based criteria over the essential workers for now. Because again, when we started at PAM, we thought, oh, we got to go to the food service workers, public safety, and teachers. We just didn't know how to validate who is who. And then, I mean, the issue about people jumping through the line comes to play. But is it really on us to decide that? And I think it was helpful that the state decided, let's go age-based first, so that takes the burden off of us. But I do think those questions, those are big ethical questions. Who in our community, in our nation, should really make the call for us so that we just follow and go and take the pros and cons with it? I feel it shouldn't be on us as a healthcare system to individually to figure it out. Welcome others' thoughts.
And Jessica and Nancy Ibarra, you're here from California Department of Public Health. Feel free to unmute yourself and comment if you'd like. Who's responsible?
Well, it's sort of
Hey everyone, this is Jessica. I think these are amazing presentations because they really clarify and confirm to me the importance of being able to give providers the freedom with guidelines to make decisions that work for their entity. I think the information we get continues to change, supports change. I mean, I guess what I'm trying to say is I would be concerned if our guidance from the state or the federal government became so restrictive that any provider couldn't get those shots into arms. So let me just leave that there and let you know that I'm feeling more excited about this call because you never know. Every region is different. To put more demands on regions that may not have the bandwidth to do what has just been described would need other options on the table. And so I think giving doctors the ability to, get the information, develop the teams, communicate, all these things I feel are important for health systems to have control over. That's my personal opinion. I'll share that now. I know the department is providing guidance, but that is very much what it is. And my only ask would be that as you move through all of this, that you're connecting with your local health department, because in the end, we're wanting to have a sense of what the movement of the vaccination is, and that some of these records are put into the immunization registry, and I don't know how much information was provided when the vaccine just showed up on a desk or on a counter when you were not expecting it. So I know, again, there's a lot to be desired in this rollout, but my hope is that as we move forward, those kinds of connections and networks are shored up.
Thank you, Jessica. I'd just like to say that in answer to the question of who should make the decision, I really think that we should be paying a lot of attention to the National Academy of Medicine. So we looked at Art's slide, which was originally slide number 22, that said phase 1B should be people of all ages with comorbid and underlying conditions that put them at significantly high risk. And I wonder if we could, within each 5-year tranche, going backwards in time, look at those who are most vulnerable according to their comorbidities and put them first. Is that impossible, Dr. Yu, based on your electronic medical records?
Well, we do have those markers over there, so we can do that. So I think, I mean, one of the things we're looking at, there's an age cohort, and then at one point it was that people with comorbid conditions with a younger age band can come in. And then is this kind of Lord of the Rings, wherever can get in and get the shots, or how much structure do you put it at to adhere to what we're supposed to do? So I think those things do come up. But again, probably my end point is just that for our system, and I think we're prepared to vaccinate within our region to close to 50,000 patients a day if we need to. So that if you look at that, that means we can probably vaccinate 250,000 patients a week. So if the vaccine supply is robust, let's just get through it as quickly as we can and not have these debates and let every willing person to come in. To me, that will be the solution out of this. Then we can take away all these ethical debates that we are spending time on. This is only happening because we have a supply constraint. I don't think it's an operational limitation, at least in our region. I do think it's a vaccine supply constraint that I know with time this will ease, but the quicker we can do it, the better off we are. Thank you.
Ed, this is Bob Kaplan. I was just curious, and maybe this is in response to Hattie's question as well. So, I just looked at the California data on deaths by age, and so we still are at about 75% of COVID deaths are people 65 and over. And it looks like it's about 1 in 5 are people in that interval between 65 and 75. So that if you really want to drive down the death rate and the hospitalization rate, why not really double down on that on age as opposed as the primary category for prioritization?
Well, I think that's indeed what the health systems are doing. It's easy for us to do. So our next group, we're going to bring in our age 65. I think it goes back to Art's slide earlier. Then how much down the line do you want to do that versus their occupation-based exposure that arguably is driving a lot of the community spread as well? At what point do you pivot to bring them in, right? I can start at age 65, but do I vaccinate 50% of them? Then I open up for others, or do I go deeper? So those are some of the questions that do come up that I think we have to figure it out.
Can I just comment? This is Mike Criqui. At UCSD, they decided to go through their patients and develop a risk score. Somebody brought this up a moment ago. I think that might have been Hattie. And so their risk score includes age, gender, skin color, hypertension, diabetes, obesity, all these other comorbidities. And they also weighted for what part of the county you're from. The South County and the East County have had higher rates in San Diego than the coastal counties in the West. And so that's an objective way. They have a cut point of 10. I don't know exactly how the score works. I wasn't involved in constructing the risk score, but they have this cut point and they're going to go with over 10 first. And that's fine. But if you look at all the comorbidities and compare them in terms of the risk of age by far dominates. So in West Virginia, they just said SOW, save our wisdom. They started from the oldest people going down. They did the same thing in the UK. They don't have healthcare workers or necessary essential workers. They just start with the oldest people. That's why you saw on the very first day of vaccinations in the UK, there's 102 years old sitting there in the vaccine. And
Mike, could you just slow down a little bit because it's hard to understand you when you talk too fast. It's just a little blurred.
Sorry, I'll go a little bit slower. So I was thinking that I wanted to use my time efficiently. But I periodically calculate the risks in San Diego. So I just did it while we were talking. Compared to somebody 20 to 29, your risk of dying of COVID is 789 times greater if you're over 80. So, I mean, when you have a relative risk of 789, you go, ooh, and that's the biggest number I've ever seen. If you're if you compare 40 to 49-year-olds, the risk is still 79 times higher. We just don't see relative risk like that. So we're talking about, magnitude and orders of risk well and beyond. Now, there is an argument about, well, how much life expectancy is there in these old guys? How long do they have to live? Well, you don't know for sure, but in order to say you're saving more lives by vaccinating younger people, you'd have to find, it's virtually impossible with the amount of life extended remaining to beat a relative risk of 79 or 789. So it's probably going to work out that vaccinating the older people saves the most person years as well, in terms of, years left for survival. And so I think that the other thing that you got to remember about vaccinating old people and sick people versus young people to prevent spread is the impact on the hospitals. It's the old people who are taking all the hospital beds, cramming the ICUs, cramming the morgues. So there's that issue as well. It's not just trying to preserve the most years of life left and life expectancy. It's also being able to keep the hospitals from being overrun.
So can I just say that I don't disagree with what you said, Michael. This presupposes that your most important priority is reducing mortality. And that may well be a decision you want to make. But other people might say we need to use the vaccine first to vaccinate teachers so we can get them back in the classroom. Other people might say we need to vaccinate prisoners because they're in a congregate setting and they deserve protection as well. And so to say that the most important thing we're going to focus on is reducing mortality is one particular value, and it might be the right value, but it isn't the only value.
I agree, but hospitalization, I'd say hospitalization and mortality.
That's fine. Okay.
The reason we're up in arms about this virus, we're up in arms on influenza. It kills people. We send kids to school and influenza epidemics. In fact, the best way to find out if you're having an influenza epidemic is the absentee in the schools. When it gets above 25%, you can almost guarantee influenzas in the community. So,
but Michael, we don't have teachers refusing to go to teach during influenza season.
Well, yes, but I mean, the vulnerable teachers in the older age group, and there are some over 65, that's fine. But is it really, I'm sort of in favor of keeping the schools open. If you have younger teachers and younger kids, why not?
And one school system in Georgia that took that approach just had to close because so many teachers were either out sick or refusing to come to school. They couldn't staff their schools. Okay. So I'm just saying there are different values beyond maximizing reduction in mortality. That's all.
And you know what? This is Jessica again. I think this very conversation about values is the very reason my limited experience, because I'm here with lots of elders, what I understand is every community needs to decide their values independent of others.
Well, that may or may not be a feasible strategy. Saying that
but the thing is that there are so many other issues that are, what I can tell you is that doctors are having their lives threatened. This is no joke. It is civil unrest. So that I believe that every health system is going to know what they need to do to get those shots in the arms, and we do not want to restrict them in a way that they create more harm to themselves or patients. That's all I'm saying, because I think that what I've seen in the past is it's just so refreshing to receive shots or, a plan and know that you have the room as a physician, as a leader in a health system to make those decisions as you need in an environment where people feel that they can have dialogue with you. That's all I'm saying, because all these things are real and it's not simple, and every community is different. And so what we can do, Hattie, is definitely share with the science and the work that's been done on the guidelines and really push the guidelines that matter. But at the end of the day, you need to give the physician the freedom to do what they need to, because as was just described by Ed, oh my goodness, I can't even imagine the pressure. And the fact that you had the freedom with your team to do what you needed to do 50 in that first day, you know, to do 500 the next day, that's awesome. So I'm just, yeah.
And you have a very comprehensive program to deliver. The state of California, current numbers today are that of delivered doses, only 46% are injected into individuals, meaning that half of our doses in California, and this is true of other states as well, California is not unusual, are not being put in. In your comprehensive plan with flexibility in all your decisions, do you know what percent of delivered doses actually are currently in patients right now? And would you say, if it's a very high number, that the rest of California should perhaps adopt some of your policies?
I think we're learning on that. So we delivered, I think we're about 60%, because right now, when the vaccine comes to us, it's designated as first dose or second dose into this. So we haven't gone to too many second doses yet. And I think that's one of the things we're learning, how the state wants us to report that. Right now, because of vaccine, we have to address the second dose one. So I think that's really timely, this issue in that interval. How permissive do we want to be? Because as more second dose, we're not able to move into first dose as quickly as we have. And in fact, we have vaccine appointments for that specific issue. So to me, I don't know whether counting first or, and people are hoarding. I mean, let's just face it, they're hoarding the second dose for that particular reason. So I do think the way how we report that, and it'll be very interesting, because I think they're tracking completed series, and I get that. But then again, whatever you have to metric, it drives behavior. So I think whether we should focus more, get as many people their first dose as possible, is kind of what we want to go to. That's our approach. So it'll be interesting from the data reporting standpoint and the messaging to see how that evolves. And now when the state is allocating vaccine based on how much you used, that will accelerate our effort to deliver more vaccines, and a health system like us who are poised to do well. But again, I feel then thereby are we disenfranchising other systems who have more challenges delivering it, and we don't want that to happen either. So all these ethical questions do come up. Thank you.
Thanks for bringing up that comment. We're going to move to the next section of the program, but we can continue this debate certainly after. It's a delicate balance between choice and ethics and responsibility, and we've heard both sides of it here. But of course, without widespread implementation of the vaccine, COVID will continue to be an issue, and physical distancing measures alone, as Dr. Reingold first mentioned, is not enough to end this pandemic. It's really important to recognize the impact of COVID on the healthcare system and how it's actually exposed our vulnerabilities in a big way. And who better than Dr. Steve Shortell with his MBA, MPH, and PhD in behavioral sciences and experience as former dean of the Berkeley School of Public Health and founding director of the Center for Organizational Innovation Research Choir and the Center for Lean Engagement and Research CLEAR, to sort of guide us through this discussion about healthcare, the healthcare system, and value-based care as a potential way to improve our system. So I'm going to turn it over to Dr. Shortell, and then we'll have more Q&A afterwards. Thank you. And Dr. Shortell, you're muted.
Can you hear me now?
Yes.
Okay.
Sounds good.
Thank you. Sorry, I got bumped off periodically there. This has been a great set of presentations and discussion. I'm going to try to, in a very short period of time, sort of link some of these topics. And I'm going to do that by just starting out. You can keep the lead slide on there for now by doing a little bit of ground setting in terms of looking at the COVID response and the rollout and the distribution, along with the great work that the Right Care Initiative has been doing over time in your leadership, Narola and Dr. Stock and so many others, in terms of reducing death and morbidity from heart disease and strokes and so on, and the underlying diabetes. And I just want to recall the Iom Report of 2001 that many of you, I think, are familiar with, that outlined the objectives and criteria for a high-performing health system and if we're going to be healthy in this country. And just as a brief refresher, they were that for each of us and all of us, healthcare should be safe, it should be effective, should be efficient, should be timely, should be patient-centered, and should be equitable. And if we put those criteria up against what and Dr. Yu and Bob and Dr. Criqui have been discussing, I think we can agree that the vaccine itself is safe, okay? And it appears to be effective as far as we know. But in those other criteria, as witnessed the discussion and questions, it's really a question mark of the extent to which we're taking into account patient priorities and preferences, and it's a very complex set of issues there, and also taking into account the timeliness of all of this, and certainly the equity factor has come up, as Dr. Yu has mentioned. Well, those same criteria can be applied against the RCI initiative in terms of reducing morbidity and mortality from these conditions. And are we reaching enough people such that our treatments, our interventions, our self-management, our approaches are safe, effective, efficient, timely, et cetera, and equitable? And so I just want to call that out at the beginning and make a transition, I think, to the next slide, which is one of the big levers around healthcare reform is we need to start paying for health and prevention and quick restorative care that we haven't been doing. And over the last few months, I've been working with a group of people at the bottom. This isn't my own work, but some of the others there that you see as well. For example, Elizabeth Mitchell heads up the Pacific Business Group on Health out here in California now. And Gail Walensky has been a past director of Healthcare Financing Administration, now CMS, and others. And George Halverson ran Kaiser Permanente. And so the suggestion going forward is we need a better way to pay for care in this country that's going to really reward better care, that will eliminate the inefficiencies and waste and streamline. And Dr. Yu talked about the lean management system and some of those tools and philosophy and culture that can help out. And the idea is to pay for prepaid, risk-adjusted, per member per month, create health budgets that are going to create the incentive for all of us to innovate in how we deliver care. And we have many, many examples. I mean, Kaiser, of course, has been the model out here for decades, is financed and pays that way. Of course, they're a fully integrated health system, but there are other examples as well. And in the Right Care Initiative is an example of the innovations around the triangle that Hattie showed earlier, pharmacists on the care team. Well, when you have an upfront health budget, you are empowered and innovated. You have your revenue up front and you can try out new things. But when it's this fee for service, and can pharmacists bill independently? Can nurses bill independently? I got to, be concerned only the physician can bill, et cetera. It's a big negating factor to what we would like to see. So traditional fee for service is not going to get us there, and it's not going to sustain any expansion in insurance coverage or as we try to recover from COVID as well. So the next slide, and I just have a few so we can get into our Q&A. So the distinct advantages of creating these health budgets are, as I've indicated here, the incentives for new models of care. Atrius is a big primary care group in Massachusetts. It's developed a hospital at home to work with some of these patients, higher quality and lower costs. Bellin Healthcare in Wisconsin has an advanced patient care model, patient-centered medical care model. And to bring it back to COVID, there is scattered data. I haven't seen any systematic study in the literature yet, but a lot of talks that there are a lot of people I've talked to and others is that when you have this predictable revenue flow, they've done a lot better under COVID as opposed to those that are depending on that fee for service. So they've had to cancel visits, they've had to cancel surgeries, elective, and so on, and they're hurting financially. One primary care group in the Bay Area, I won't identify them, at least a few months ago, said they had 6 weeks before they were going to go broke. And I've heard stories like that around the country as well. So we need to create an upfront, predictable revenue stream to provide better care every day. Next slide. And the evidence is beginning to be overwhelming. I'll just very quickly cite a little bit of it here. I can give you references as well. Already paying upfront in terms of per member per month, capitated budgets, if you will. Medicare Advantage does that. Traditional Medicare does not. It's fee for service. And some of the evidence that we have around some of the evaluations of this, I'll just give a few examples. In it's higher quality, lower cost. There's been studies done with comparison groups in which the Medicare Advantage have outperformed the non-Medicare fee-for-service. For example, 50% more frail elderly and 52% more patients with complexity and chronic conditions have received pneumonia vaccines. 79% of patients with diabetes have received an eye exam versus 51% in fee-for-service Medicare. These are matched comparison groups using propensity matching. 43% lower rate of preventable hospital admissions, 2 to 12% lower rates of 30-day hospital readmissions among high-cost, high-need patients. In California, we have data from the Integrated Healthcare Association showing consistently higher quality and lower costs for our physician groups that are accepting full risk. Risk adjusted, to be sure, you can argue about better measures of that, but nonetheless, the quality and cost data. And I could go on, but the point is that the evidence is mounting and there's no evidence of cherry picking. There may have been 5 or 6 years ago on Medicare Advantage, but recent studies, people at Harvard and others have found no cherry picking. Next slide. So for discussion, I'm going to wind up with this. We are working on and welcome your ideas, and probably this is a continuing conversation, how we get key stakeholders support. Hospitals in particular may push back from this because under these kinds of paying for care, the hospital really becomes a vendor and a cost center, not a revenue center. The goal is keep patients out of the bed, out of the emergency room if they don't really need to be there. And so how are we going to negotiate these upfront budgets? How do we adjust for the social determinants of health? The deprivation index is one, and income in particular by zip code can be used. And how can this be used on the federal Biden, we're working Biden and Harris group, but also the state, what we can do here in California to put it on the exchange as a public option. The public option, in other words, would pay for care based on these health budgets. And again, of course, adjustments for rural areas in California and across the country, network adequacy issues, related issues such as the availability of broadband. So let me end there, and maybe that keys up a few questions for discussion now and hopefully maybe more in the future.
Thanks so much, Steve. And maybe just so we're all on the same page, can you comment on who's paying for all this COVID-19 vaccination right now?
Yeah, so on the COVID-19 vaccinations, they are asking, and I'm getting mine at the John Muir Health System, I'm scheduled for Friday. They are asking for your health insurance card if you're Medicare or have commercial insurance. So I think some are going to bill for that. It's free in the sense of your insurance covers it. And if you can't pay for care, my understanding is it's going to be free. If you can't pay, if you don't have insurance coverage, it's going to be free. But I think the providers, and maybe Dr. Yu can respond in terms of Sutter, if patients have health insurance coverage, they're going to try to bill for the cost they're incurring in standing up all the vaccination processes that we're seeing.
Ed? Ed, are you there? You want to comment on, are you billing? And if
sorry,
not, okay.
Dropped off for a little bit. Can you repeat the question one more time?
Are you passing on the cost of, you know, the COVID administrative setup essentially and the vaccine to the insurance companies?
So right now, the administration costs we are building a charge for the administration of that. We don't know what's going to happen to that. And I think this is also coming up in our risk-based plans about the division of financial responsibility on this. So just still learning.
I just wanted to comment, in LA County, it's $20 per vaccination on average. And so the plans are paying, as was mentioned. If patients don't have insurance, the feds are paying. So it's does pay for some resources.
Yeah.
The intention at the federal level is that no patient should have to pay any cost for the vaccine or its administration.
Yeah.
All right, let's open it up to the group for comments. And Bill Baumer, and if you have any comments you'd like to make now.
Yeah, I think, Steve, that was a great presentation. It's interesting that if you look at our healthcare in the US, we're basically twice as expensive as any other country in Europe, and certainly much more than other countries. If you look at your Medicare Advantage program and the savings there, is it in the neighborhood of a 2-to-1 cost savings versus fee for service in the other Medicare population? Or is it a more modest reduction?
Yeah, by and large, Bill, it's a somewhat more modest reduction. It depends on the metric, of course, that you choose: inpatient savings, primary care savings, et cetera. It's not quite the data that I've seen, a 2-to-1, but it's fairly substantial. And, you know, there was a lot of skepticism 3 or 4 years ago that maybe Medicare Advantage is cherry picking and so on, but these are matched to the extent you can, risk-adjusted comparisons. So the point is that the provider networks that are taking Medicare Advantage patients have this upfront, you know, whatever member it is, they have a budget there to really keep these people well and to manage their care well and prudently. And that's beginning to show up in the data. And the point our group is making, as we talk here in California and trying nationally to some extent as well, is if we can get some savings from delivering healthcare better continuously every day and keeping these people well, we can potentially, of course, the political is another, we can potentially redistribute some of those savings from medical care to creating healthier communities and environments, which are also, if anything, the real producers of our health. We want to prevent the heart disease and the strokes and the stress from living in poverty and bad diets, et cetera, we need to really invest more in these social determinants of our health. Well, to do that, right, we've got to do something about redirecting some of the resources now going into the formal healthcare system. So that's sort of some of the motivation behind some of the work. You always want to look at the evidence, and so far it's been fairly encouraging.
If you look at your data, which shows that it's potentially cheaper, Medicare Advantage, and better healthcare by your numbers, more effective, why do you think it is that only 4 out of 10 Medicare patients have seen that advantage and are going there? Because we have to literally convince the other 6 out of 10 in Medicare that they could migrate to a better and cheaper program.
So it's been growing, Bill, terrifically in the last few years. It's gone up from 27% to a near 40% now, but you're looking at the glass more than half empty rather than going full. So it's really the direction. So it's increasing, it's becoming increasingly popular. And I think part of it is a habit, inertia. Older people, you know, I've been in Medicare fee for service, et cetera. The information is just beginning to get out. Here are some options. You can get a few more benefits if you go Medicare Advantage, et cetera. And so I think it's going to take time, but I think we're going to continue to see that option grow for Medicare.
So for some places like Canada, they made an executive decision to go to a program like this. Do you think that's what will be required in the US, is to go to a Canadian or UK system on an administrative level?
I don't think so politically. This is the Medicare for all kind of approach, for example, and that may be aspirational. I'm sort of pragmatic. Let's take some other steps. There's just too much experience in our country with employer-based insurance and private commercial insurance, and there's a lot that they can do too to make things better. So I think this, the idea of offering something like this as a public option choice, at least, by a state, for example, would be the way to dip our toe in the water and gain experience with it. I noticed a question came up about provider networks offering Medicare Advantage. There's restricted networks, and some Medicare enrollees don't like that idea because they think if they go into the Medicare Advantage, can they maintain their current physician, their current provider network? And the answer to that is going to vary. It's going to vary all over the country. It does vary all over the country. But that is something that you want to check very carefully. If you go to a Medicare Advantage plan, who is the provider networks that accept those patients? So that's another factor that may be slowing down to some extent the expansion of more people into Medicare Advantage. You want to know what provider networks are involved.
So let's open it up to other questions. Any other questions that we have for Steve?
And I guess I have, oh, go ahead, Hattie.
Raleigh. Go ahead,
Please.
Neural.
Please, Hattie.
Well, I've worked on health reform since the beginning of time, I think since I was a teenager. I didn't go to medical school in part because I was quite disturbed by what I saw in the emergency room setting about really poor scientific practices and discrimination issues based on insurance. And since then, I've done a lot with Steve Shortell and with brainiacs around the country on health reform. I think one of the great hesitancies about going into a prepaid model is that we have not perfected the emergency exit clause or a fee-for-service wraparound, so that if you're in a prepaid plan, for instance, I'll just say Kaiser because I used to regulate them, and they don't happen to have the capacity, for instance, that Stanford does to treat your particular special problem that you didn't know you were going to have when you signed up for insurance. You need to have a financial mechanism that is not simply cash pay to get to the right specialist. So I think if we could allay the fears that no, you're not going to be able to get to Bill Ballmer at UC Davis if you happen to develop some terrible heart condition, or to Nirali Vora at Stanford if you happen to develop some terrible neurological syndrome. I think that what's prevented the spread of the prepaid model. And I also have to say, as a regulator, if we're going to be pushing people into prepaid models, we've got to become much more sophisticated regulators, because I think, Steve, you remember, and we will not say what health system CEO it was that said to us when we said, why don't you join up in the Right Care Initiative? Why aren't you all participating? And they said, if we do all the preventive things that you're recommending, we won't have enough heads and beds to keep our doors open. So that there are major ethical issues. And one has just come up in the last couple of weeks where a prepaid plan has announced that they are taking a heart medication off the formulary and these are for high-risk patients. I think they're doing it to for purely financial reasons, to sort of create a float time where they're not going to be paying for it. They will eventually be forced to pay for it by the Department of Managed Healthcare, because all medically necessary care is required. But here we are in a situation where our emergency rooms and our ICUs are slammed, and yet taking these patients off these medications are going to cause more cardiovascular events. And so just because you're prepaid doesn't mean without a sophisticated scientific regulatory structure, that prepaid body is going to make the proper decision. And in fact, Bill sent me a slide this morning. Bill, can you share your screen and share that slide? I had no idea that this had happened, and it's an example of why we really can't oversimplify to hope that we'll have good incentives. So Jenny, you could possibly help him with the slides if you Bill.
Can you see my screen?
We cannot. So how about if you just tell Jenny which slide you want up?
All right, Jenny, why don't you, let me go back to that. Pull up the extra slides I had, and I'll just spend 10 seconds on each one. So,
well, while she brings them up, I'll just say that Steve Shortell and Bob Kaplan have been absolute heroes on this issue of helping the Department of Managed Healthcare to better regulate, to ensure that the basics are being done. Lipids are being controlled, blood sugars being controlled, blood pressures being controlled. That system has not existed in the state of California to pay attention to what's happening with those prepaid dollars. So a lot of the founders of the Right Care Initiative created a greater knowledge base at the state for paying attention to what really matters. And so anyway, Steve, thank you for creating that data structure with PPGH and with other organizations, Leapfrog, et cetera, where we actually can tell what's happening. And
Yeah, IHA too.
Yeah, I forgot their name because I'm not good with acronyms.
Right.
Let me just quickly go through this slide. Just shows the number of individuals in each state who have received immunization currently. And you can see it's roughly 5%. So we're way behind in COVID immunizations. Next slide. And this just shows what I said was the percent that actually was injected from the delivered doses. And you can see California's at 46%, but there are some states that's, we listened to Ed's presentation, like North Dakota, 87% of delivered doses have actually gotten in patients. So there is a way to do it. And the reason I pointed out is this could literally double the number of injections that we saw on the prior page, 4%, if we actually got the delivered doses in the patients. Next slide. And this just shows that even some other countries have a little better immunization record than does the US at this time, even though we in fact originated most of these tests and doses. Next slide. And this just shows we're still at the peak of the COVID as far as deaths. It seems to be flattening out right now on the lower scale. So we still have about 3,000 deaths a day that we're dealing with. Next slide. So this was the issue that I think Hattie alluded to, and that is one of our Bay Area hospitals that you're probably familiar with did get an epidemic of it in the hospital, and 43 cases went up to 99 cases that they have. It started in the staff and then it spread to the patients. It's very important that these clusters be reported to CDPH so that we can be aware of them especially for the reasons seen on the next slide, and one more after that. One more slide, is that these cases that were found in the Bay Area at the Kaiser outbreak are the variant. So this is the new variant spreading in the South Bay that is leading to it. And that is now spreading across California. So the ability to report that, identify it, and then perhaps invoke additional restrictions or in that area related to that hospital are very important, especially for the hospital to focus on what's going wrong in their situation that needs to be corrected to prevent that. So clearly we have to be aware of that. It's not specifically, I think, a Kaiser thing, but just the best intentions here. And that was to reduce COVID led to a problem of unintended consequences of an outbreak in a hospital that then spread to the patients at that time. So it is a problem, and because it's a variant, the more this variant gets out, the more we're releasing it onto the general population in California. So a continuing problem that we have, Michael said that one option is to vaccinate more people. I totally agree with that. This would prevent these variants from getting a chance to spread. And I think Mike said that if we gave only one shot, we would double the number of doses that we have available. And I think that's a reasonable possibility in view of a deadly epidemic that would save, as he estimated, 55,000 lives for it. He said he would bet on that. Being a gambling person and playing poker, if he's going to raise his bet to give only one shot, I would like to match that and double the bet or increase it by saying that not only do we have to perhaps give just one shot to everyone, but we have to go back and instead of giving out 100 million doses in 100 days, we have to double that to 2 million a day to 200 million. We have literally, if we have to give 2 shots to everyone in the US, that's approximately 600 million doses. And then 1 million doses a day that we're putting out. It's going to take us almost 2 years to get to herd immunity before we can reduce the economic and social and healthcare problems that we have. So I think we have to do a number of things in this COVID pandemic, and we need to get more quickly to herd immunity. And we do have to track these little clusters or outbreaks to make sure that that variant doesn't get totally established in California.
Thank you, Bill. And so I'm going to extend the metaphor and ask Ed, do you call at Sutter? Are you going to call or does the Department of Public Health need to call and tell you to do that? What do you think?
Well,
one dose strategy.
Well, the thing that I see is that, again, I don't think it's a vaccine delivery barrier. If we have enough vaccine, whether it's 1 dose or 2 dose, it won't matter. And I think the game changer we're looking is when the Johnson & Johnson 1 dose gets approved. Rumor has it it'll be approved within the next few weeks or so. Then this will then change the discussion because I anticipate patients will want that one over the other ones. So I think there's many more chapters to unfold. And indeed, we may have a vaccine that is a 1 dose one, making this other point moot. Thank you.
Ed, one of the old plans is to keep it simple. And one of the things you said was you were getting doses that were labeled as dose 2. You had to hold those. And why don't we just make it simple? Because I think if we made it so simple that here's your dose delivery, just keep giving it to patients based on age, a more simple thing that can be verified, that might allow us to increase the number of vaccinations per deliveries. And now you're not sitting back with additional restrictions. The more things you have to check and verify, and that patients who are elderly can't really figure out online well, the simpler we can make it, I think the more efficient we can make our delivery system.
Yeah, I agree with you. So I was kind of surprised that the delivery came with designation first or second dose, and I'm not quite sure why the database was set that way. This is in line with, I think, the desire of the CDPH to give healthcare system the freedom to get shots in arms. So we will welcome that. However, I think right now, because of how it's structured, they are designated first and second dose. Now, how they're going to track whether we're going to do it or not, we don't know. But I think we're honoring the intent of how they were delivered to us. So I agree with you. The more flexibility we have, the better off we are. And our intent here is to get these as many people as we can. Thank you.
We have a few more minutes for questions. We're going to close at 6:30. Jessica, I have a question for you, actually, while people are thinking of this. You know, this issue of disparities is very real, and how to equitably get the vaccine to those who really need it. Are there strategies that the county is using, especially to tackle this issue of who has access to technology, where that has been such a critical piece facilitating people scheduling doses? What else is the county suggesting or doing to help those that may not have access and can't wait on hold, you know, on the phone for hours? I don't know if Jessica's with us, so.
I'll just, while we wait for Jessica to join in, I'd like to ask Art more about that National Academy of Medicine priority list and how California dealt with it, because it seemed to be fairly elegant, and it seems like it would be more straightforward and faster than what we're doing.
Well, the reality is, you know, National Academy reports are there for people to read if they want to be informed by them. I think it's to a certain extent been supplanted by a very similar process undergone by the ACIP. And you could argue that the ACIP and CDC and the federal government have more say in the matter than a National Academy report does. In fact, there was quite a bit of discussion among several of us when we were asked to be on that report committee, when we knew that the ACIP was doing parallel work. Why the hell was there going to, why were we doing this? What was the point? And we weren't even allowed to talk to the ACIP because CDC was the sponsor of the report. And as Steve knows quite well, you can't talk to the sponsor of the report while you're doing a report. So, you know, it was a parallel process. Some of the things are very similar. Whether anyone, you know, cares about what's in our report, I don't know. But I think generally, you know, events on the ground, and you've heard a very nice discussion about all the challenges. Events on the ground have meant that Florida is doing one thing, Arkansas is doing something, West Virginia is doing something else, and different counties in California may be doing different things. And, you know, and all of it is changing almost weekly. So it's a mess.
Yes,
however elegant our report was, the reality on the ground is a mess.
Yes, and this last minute, I just want to say you are correct, Dr. Reingold, that we at the state and in partnership with counties are working very hard to listen, to try to navigate. There wasn't a lot of coordination at the federal level. There's lots of demand, there's lots of communication issues right now, and they will be employing various strategies like bringing in funding with community-based organizations jumping in to help to navigate this equity chasm that we have. And so stay tuned, and obviously I really am grateful to all the presentations today because it really speaks to the commitment of this group to address these health equity matters. Thank you.
And with that, I think we've reached 6:30. I guess, you know, this is the University of Best Practices. So as we face these unknowns together, I hope that we can continue the conversation even off this